the Administration for Strategic Preparedness and Response within the U.S. Department of Health and Human Services, and it is designed to help healthcare be better prepared for and respond to major emergencies. Obviously, we're all aware of the current crisis with pediatric respiratory illness that we're facing, and the real challenges with capacity that make it harder to find appropriate receiving beds for those that need hospitalization, and also just making all of us see a lot more acutely ill children with acute respiratory illness. We are very grateful for our support from ASPR, the Administration for Strategic Preparedness and Response, for this webinar series. And the series that we have for you is designed to help you all better prepare for, diagnose and treat children with acute respiratory illness in this surge that we're seeing. This is the first of six lectures, that we will be presenting over the next 6 weeks. It's going to be one webinar per week, each focused on a different topic. And appropriately, this first webinar that we're presenting to you is focused on the assessment and management of the child with acute respiratory illness. We hope that this is helpful for you. This series is designed to be multidisciplinary for providers, physicians, nurse practitioners, physician assistants, others, as well as our nursing colleagues, respiratory therapy specialists, who all are clearly working together to respond and manage acute pediatric respiratory illness right now. We're very, very excited to present some fantastic speakers that we think are going to be very helpful to all of us as we improve our ability to manage children. During this webinar, we encourage you to submit questions. Please use the Q&A button down below in order to support our answering your questions. We will do our very best to answer them as they come through. So you can use that Q&A box for us. At the end of the webinar, we will be sharing a short survey link. We would really like you to fill out the survey if you're able. Tell us what you liked about this webinar, what you'd like us to address in future webinars. Please feel free to suggest any topics that you think are of particular importance. So I would like to introduce our 3 speakers today who are here with us. The first is Dr. Nicole Nadeau. Dr. Nadeau is a pediatric emergency medicine attending physician at the Massachusetts Hospital for Children in the emergency department. She serves as the associate division chief for pediatric emergency medicine, and also is the lead for pediatric quality and safety within the emergency department at Mass General. She completed her residency training at Yale New Haven Children's Hospital, where she served as chief resident, and completed her fellowship training in pediatric emergency medicine at Boston Children's Hospital. She is deeply interested in quality improvement and patient safety in her work in the emergency department, focusing specifically on also the care of critically ill children. We're very fortunate to have Hannah Pingerton with us as well. Hannah is an experienced emergency nurse who works in our pediatric emergency department at Mass General Hospital. She is a graduate of the Connell School of Nursing at Boston College and has more than 9 years of nursing experience specializing in the care of pediatric patients. We also have Daniel Chipman. Dan is a respiratory therapist and the assistant director for respiratory care services at Mass General Hospital. He has decades of experience in the management of adult and pediatric patients, but a lot of pediatric patients with acute respiratory illness. And he's published extensively on mechanically ventilated neonates and children. So really 3 fantastic speakers who have treated an awful lot of acutely ill children in their careers, and we're fortunate to have them here with us. So Dr. Nadeau, if I can ask you to pull up your slides, we're going to get started.
Yes, absolutely. Get them okay?
Yep, so we've got them right there. You can go forward 1 slide for us.
Absolutely.
Again, these are our speakers. Next slide. Do want to acknowledge, sorry, Dr. Nadeau, if you can just mute for 1 second for me. That this webinar again is produced out of funding and support from ASPR. Next slide. And we do just want to make it clear that we're grateful for the support, but the content that's being presented and discussed in this webinar represents only the individual speakers and not the U.S. government. This also does not constitute medical advice and is our best attempt to help with support and education. But of course, as always, people should follow usual clinical practices and use the clinical resources in their area. None of the speakers have conflicts of interest to disclose. So next slide. So I'm going to turn it over now to Dr. Nadeau, and we will get started.
Perfect. Thank you so much, Dr. Bittinger. It's a real pleasure to be here with all of you, and particularly to be here with you, with my excellent colleagues, Hannah and Dan. And Dr. Bittinger has it completely right. We are fully reliant upon each other right now in the sort of current surge of patients for whom we're caring. And so I'm very excited to be able to share all perspectives here with you. Let me advance the next slide here and just talk about our learning objectives. So at the end of the session, it's our hope that the learner will have greater situational awareness regarding the current pediatric respiratory surge, will have heightened comfort with the assessment of the pediatric respiratory patient, have refreshed knowledge, because all of this is things that I know you know. We're just trying to refresh, enhance your sort of already existing sort of great knowledge base and skill set. So just refresh knowledge.
Dr. Nadeau, I'm sorry, I'm going to interrupt you. The attendees are having difficulty hearing you. If I can ask you to speak more loudly as you speak into the mic.
Absolutely. It's almost never a problem I have in life. Is that better now?
Yes, I think so. Thank you.
Okay, perfect. Sorry about that. Trying to give you some just refreshed knowledge, reminding you of your knowledge of the management of the two sort of most prevalent pediatric respiratory presentations that we're seeing, namely bronchiolitis and asthma. And try to also just to give you some increased facility with the different modalities of respiratory support in the care of these patients. How that'll look in terms of our outline. Just going to do a little bit again about the context in which we currently find ourselves. We're going to go broadly over the pediatric respiratory assessment, and then we're going to get disease specific with bronchiolitis and asthma, and for each of them, a very brief overview, and then really focus on basic management and then more advanced support. Again, really bringing in the expert of my colleague co-presenters. All right. So in terms of current context, we're going to sort of go over the headlines that I know we're all a bit too familiar with now at this point. Just a bit about the numbers, both institutionally and then more broadly what we're seeing nationally. And then a bit about the lived experience that we're seeing here in sort of our academic medical center, recognizing that may be very different from the way that you're living the same current crisis in each of your various centers, but sharing what we can. All right. So, I know this is sort of region 1, so sort of coming from across all the sort of Northeast states, and it sounds like also more broadly, which is wonderful. Sort of dug up different headlines and sort of some of our various areas. So this is from the Stanford Advocate. What's behind sort of the worrying RSV surge in U.S. children's hospitals? And this is what we're feeling, and also what our patients are seeing, which is driving certainly some parental concern as well. Similarly, the Portland Press Herald, soaring RSV cases raise fears about hospital capacity with COVID and rising and flu looming. And then finally, what I think is sort of the most problematic and troublesome and worrisome to our community hospital partners is this, that hospitals are really scrambling and feeling the pain of trying to sort of find pediatric beds as admissions rise. And perhaps not always being able to move the somewhat sick pediatric respiratory patient out of their ED in as timely manner as typical. And so obviously all of your, even just attendance here is testament to your desire to really make sure you're as able as possible to take incredible care of those children when they may sort of be with you for longer than typical. So in terms of the numbers, these are institutional viral trends. You can see the top line is RSV and has been increasing steadily throughout October and November. There's a recent slight fall off, unclear if that's going to be a data lag versus true, remains to be seen. Certainly we all hope it's going to start to be the downslope, but remains to be seen. But at the same time, we can see the influenza just starting to show itself and that bottom line beginning to trend up. It's something we're definitely all keeping an eye on. Obviously we all know what's much more important than what viruses kids are getting is how sick they are or not getting and what resources they are or not needing. And so this is again just institutional data looking at trends in admission. And certainly we can see that since about September, admission rates have been sort of steadily climbing to where they are currently. And I think at first, I feel like it was, oh, respiratory season has come early. And okay, like it's come early, sure, our timelines are all a little thrown off, but is that important and does that matter? And I think what we're really seeing in a bigger picture as we look at this sort of national CDC data is it's not just that it's come early, it's that it's come early and it has come in a much more impactful way than typical, even at usual season peaks. So this graph, basically in broad strokes, I think the most pertinent is probably to look at the pink line down below, sort of pre-COVID baseline respiratory season that we're used to seeing. And you can see it peaks at about 5 per 100,000 in terms of rates of RSV-associated hospitalization. I'm sure it usually peaks in December to January, but like, again, does timeline matter that much? Maybe not. Here, we hope we've peaked. We're not sure yet, but certainly where we at least are so far, it's not only that it's happened so much earlier, but look at how much higher above all the rest of the lines this year is. And so 13 per 100,000 admissions, easily doubling anything we've seen in the prior 5 years. So it's really just not just that it's early, it really is that kids are really getting much sicker and admissions are certainly much higher, which is what we're all feeling. I'm going to turn it to Dan for a moment just to share a little bit. He really sees the whole hospital in a way that I don't from the emergency department. He's going to just share a little bit about the lived experience, what it's been, the accommodations that we at the pediatric centers are trying to make to take as many patients as we can. Still, of course, with some limitations, but Dan, would love to have you share what's been your experience recently.
Yeah, so the normal influx of patients, they come through our emergency department, they get stabilized, and then the disposition is either to one of the pediatric inpatient floors or to the pediatric ICU based on the severity of their illness and how they respond to therapy. Currently, there are no PICU beds on a regular basis, not here, not at Newton Wellesley Hospital, not at Wentworth Douglas, often nowhere in New England. A couple of weeks ago, the closest PICU bed that was available for a patient that we wanted to put in the PICU was in Albany, New York. So it's a problem that's been running rampant through the entire region, every hospital. So what we've done is we've taken these patients and we've put them on one of our inpatient pediatric floors. It's been consolidated there for these patients who we would often treat in the PICU, but have had to go to the floors. And to support that, we've done things like provide education for nursing. We've used devices to provide CPAP. We've integrated them with the universal alarm system throughout the floor to give people messages if patients become disconnected or things like that. And we've planted a respiratory therapist on that one floor to help support the nurses. So it's a problem that exists everywhere, and these are some of the things that we've done to try to deal with it.
Yeah, perfect. Thank you so much, Dan. So again, we are well resourced and certainly feel fortunate in that, but many of our providers that similarly are not used to taking care of critically ill children that are used to sort of just demonstrated stability, et cetera, have also had to sort of really brush up on their skills on high flow CPAP, et cetera, and really step up in the way that I know that many of you have. Thank you so much, Dan, for sharing their experience. All right, we're going to move a little bit now to the next section of speaking about really pediatric respiratory assessment, which of course begins right sort of at the door with our frontline providers, our triage nurses. Hannah, are you here to be able to speak to your sort of approach in terms of all the workup breathers that are coming in at once, how you sort of wade through the sea of them, who you really are worried about, who you sort of grab me as the attending for right away?
Yes. So I'm here. So basically, when a respiratory patient comes through our pediatric emergency room, our first nursing assessment is to just kind of look at the child, see how awake they are. If they're super sleepy, you can kind of gauge their breathing from if they're kind of just awake or not, if they're too tired for breathing too hard. Next, we're going to look at their skin color, if they're super pale, if they're cyanotic. And obviously in that case, I'm grabbing Nicole right away to come over. We're putting the patient in the room, getting them on a monitor, taking a look at their saturation and their respiratory rate. If we need to apply any sort of respiratory support, that's when Dan comes into play. We're calling him over and then kind of gauging to see high flow, low flow nasal cannula, whatever the need may be for this child at the time. He will place them on whatever support's needed. And then we're also looking at the child's retractions, if there's any tugging around their trachea, their degree of retractions as well. And then kind of seeing their ability to feed. Some children, when they're breathing so hard, it's hard for them to feed. So that's another thing we're going to take a look at, just to see if we need to place a line or an NG tube or what going forward, to keep the child stable.
Awesome. Thank you so much. And yeah, I think some of the things that you really honed in on, mental status definitely being one of the biggest things. Are they needing to be sure that children are comfortably asleep, especially infants, as opposed to sleepy? And then it's not always, sometimes those are their less experienced sort of out front. It's not always the oxygen level, as I know you know well. Certainly kids can be in trouble while still hanging on to reasonable oxygenation. With that sort of marked work of breathing, retractions, we'll talk about that a bit more now. All right, so in terms of my approach to pediatric respiratory assessment, it's the most pediatric thing I've said here, but all I really need to know, I learned and really it's the doorway. The pediatric respiratory exam is almost entirely visual. I am not obviously denying the importance of auscultation, but it is so secondary in terms of deciding who I'm worried about. It can be helpful to decide which process I think I'm going to treat and which interventions might be helpful. But in terms of if I'm worried about this child or not, if they're likely to need support, if they're likely to need to stay, it is all about the visual assessment for me. And I say from the doorway, just because, of course, as you all know entirely too well, every toddler that you go near and make anxious is suddenly retracting and grunting as they cry and scream their head off. And so really important to try to get that calm assessment. And I frequently will do that either sort of peeking through beside the curtain, if in the curtain area before the toddler is aware that I'm present in any way. Or our doors helpfully have blinds that I will open and take a look before, again, even entering. Once I even do enter the room, I will always stay at the far back of the room, and I'll let the parents know specifically, we're going to chat in a moment. I just really want to count their respirations before I get any closer. And respirations are absolutely something that I always count myself. They are never accurate on a monitor, as we know, you all know, and they certainly are accurate with most of our wonderful nurses, but it's a trust but verify situation. So again, truly from the doorway, without exaggeration, I will count their work of breathing, their respiratory rate rather. I will assess their work of breathing. I'll try to have the parents pull up the shirt. It is amazing how well infants and toddlers can compensate. They are resilient. As we all know, they make it right up until they fall off a cliff. And so they can sit there looking happy playing with Play-Doh. And when you lift up the shirt, and the retractions can be marked and profound. So really it is all visual for me and all about sort of getting that calm look. Obviously, as Hannah referenced, mental status is everything. You need to be sure that the child is not retracting, or is the rare one breathing 40, breathing a reasonable rate, that they're doing so because they are on the right side of the curve, but they are not yet worsened to the point of needing intervention, rather than the wrong side of the curve, that they are breathing 40 because that's all that they can breathe. And so just being really careful to sort of put that data together in terms of how awake they are, how well they're feeding with that respiratory rate and work of breathing, make sure it's not sort of a relative hypopnea. Otherwise, you all certainly know what you're looking for. The one, toddlers can be so hard in so many ways, but veterinary medicine, they're not going to tell you what hurts, et cetera. But the one thing they really give us, unlike our adolescents or young adults, is they really show their work of breathing. So they, once, if you look, as I said, they may not show their overall gestalt, but if you look, they are going to move their chest, they are going to move their neck. It is visible. And so looking for those retractions, and they can be present. And I'll point out to parents, even if I'm sending the child home, that they saw the right thing, they were right, this is not their normal. And to keep looking for that, it simply isn't to the level it needs to be admitted, perhaps. Certainly once you start to see intercostal retractions, that concerns me much more than subcostal and suprasternal. Head bobbing, flaring, grunting, all getting towards the sort of advanced signs of work of breathing, as you all know, and are probably going to need to come in or find a process on which I can intervene. which, as I said, is really where the auscultation comes in. Not if I'm worried, but is this an intervenable process, a rapidly reversible process, such as an asthma reactive airway, or is this something that just needs sort of support? So in terms of auscultation, stridor, of course, is a bit of more of a naked ear situation and would suggest croup or some other upper airway obstruction, which is not the focus of this talk, but would have its own dedicated therapies. Of course, wheezing can be seen in bronchiolitis because it is ultimately a narrowing of the airways. And so you are hearing air passage through narrow airways. But in bronchiolitis typically will be scant, occasional, much more overwhelmed by bronchi, and still with really good air movement and not particularly prolonged expiration. You can, of course, have an 11-month-old that has, virus such as RSV that could have reactive airway on top. And that can be subtle and tough to distinguish, but ultimately, if it's really more marked wheezing or that really prolonged expiratory phase is often the most subtle hint and helpful hint, then you're going to consider that process. Otherwise, the last thing, of course, as you all know, is the history. It's critical for the most part. If I don't know the diagnosis by the end of the history, I am unlikely to. It's really how are they feeding? And I care about this a lot more than with like, they are gastro kids. Gastro kids, ultimately, if the hospital's full, they're not feeding well, like, well, give them 2 boluses, let them go home anyways, see how they do tomorrow. Here, feeding really is a sign, do they have that respiratory reserve still, or are they about to sort of fall off that cliff? So it can be a really important marker. And then what's their trajectory, like we said, are they sort of on the right or wrong side of that curve? Put in their work of breathing, their respiratory rate in context of that. All right, getting a little bit disease specific now, moving to bronchiolitis. So as you all know, disorder of the lower respiratory tract caused by common viral pathogens. It's really not. It becomes almost synonymous, is used almost synonymously with RSV. But of course, as we all know, it's not truly any one virus. It's really a clinical picture of lower respiratory compromise. 1/3 of children hospitalized with bronchiolitis will have a different virus that is not RSV, but the same sort of clinical picture, the same care. And then importantly, and I think this is helpful for the parents that are going to be coming to you anxious about the headlines that they're seeing. Parents now, they never sort of cared before if their 4-year-old had RSV, but this year they do. They want to know if that stuffy nose is RSV, especially in the younger ones fairly. And so important to tell them that even of those who do swab positive for RSV, only 40% of those children under 2, so the most vulnerable, will even develop bronchiolitis, meaning sort of lower airway involvement. Never mind the small percent of them that will need to be admitted. So while it is important, while it is certainly giving some kids a hard time, there's plenty of room for reassurance to parents that most kids still do very well with this. As you well know, the pathology itself is basically the direct plugging of the mucus, and then also this sort of terrible insult to the lungs themselves with edema, inflammation, and even necrosis of the airway lining. And therein sort of lie the difficulty with air exchange, et cetera, and some of the potential long-term sequelae that won't be discussed here. And again, not surprising to any of us, it's the most common cause of hospitalization in the first 12 months of life. So basic management, the very not scientific way to say this is it's really just a whole lot of TLC. Turning that into something a bit more scientific, you likely are all somewhat familiar. It's not particularly new with the AAP clinical practice guideline on bronchiolitis. And I think, incredibly helpful, and the sort of the rare disease entities for pediatrics on which we do actually have formal guidelines. This is one of them. Most of the evidence is what not to do. Albuterol, steroids, racemic epi, saline nebs for the ED anyways. Chest physiotherapy, chest x-ray labs, and antibiotics are all explicitly recommended against in this guideline. And I think sometimes that can feel frustrating because we just feel like we want to do something. We just want to improve them in some way. But it is important to consider the downsides. If we really think this is just a straight bronchiolitis, if we don't have the clinical reason to believe it's anything else on top, which we'll talk about, then these things not only can have secondary, medication effects, et cetera. They also can agitate the child, can sort of take the end of the respiratory reserve, and so they give them the therapy that they actually need. They're fighting you with the nebs, or fighting you on an IV draw, et cetera, sort of wasting that energy that they do have. And then, of course, you're sort of setting the parents up to think like, this is a situation that has to be improved and we're going to improve it, and then we fail to improve it, but they're still dischargeable. It's fine, because maybe they are. But we may not have sort of set the stage for that if we are trying so hard with what are largely futile therapies. Of course, you all are excellent clinicians and have appropriate clinical judgment and gestalt. There are 11-month-olds that have lower respiratory tract involvement and also have a strong history of atopy or a strong family history, right? A strong family history of asthma. And so there are certainly patients that will be the exception to the rule, that will seem to truly have a reactive airway component on top of, yes, their clinical bronchiolitis. And for those patients, of course, use your judgment, use those bronchodilators and steroids. Just know it's the exception rather than the rule. Same thing for chest X-ray and antibiotics. Try not to get them for your average bronchiolitic, as you know. That said, if they've had clinical bronchiolitis for a week and now have new fever and worsened cough, of course, perhaps they have an overlying pneumonia, and that makes sense too. So don't let the guidelines take away your excellent clinical judgment. Just know that for your average patient, you're going to spend give yourself a lot of heartache, some longer length of stay, a lot of nursing time at the bedside for what may really be very low yield. What the guideline does recommend is really, if they can't feed, to give them fluids and sustenance, and if they can't oxygenate, to give them oxygen. And of note, even that, they say you can likely wait until they're not sort of making 90. If they're sort of 93, 94, et cetera, that is probably okay and probably does not need to be supported with oxygen or necessarily admission, depending on the big clinical picture. And really, their sort of key statements are that we need to use our excellent histories and exam to decide severity, and including their sort of past medical history and vulnerabilities. And we need to essentially decide who gets home level TLC and who gets hospital level TLC, is really the long and short of bronchiolitis, as I know you know, and I know you're all feeling sort of every day as you wade through which toddlers are safe to go and which are not. I will say, as you have that feeling of sort of drowning in respiratory toddlers, that the presentations are all sounding the same, et cetera, I do find it very helpful, and I think there's good data on clinical pathway use in general, to try to use objective scoring systems, such as the Respiratory Assessment score, which is validated for assessing sort of degree of severity of work of breathing in bronchiolitis. This is our pathway at MGH. Any of you listening from MGB, this is sort of newly available more broadly throughout the institution. But many of you at your own institutions, your own institution or your sister academic center may have a similar pathway. And if not, there's publicly available ones. Both CHOP and Seattle Children's are very generous in sharing all of their pathways online, and can be very helpful in giving an objective way to try to keep them all straight and who really is or is not sort of making it. Again, not surpassing your clinical judgment, just as a guide to it. So in terms of who's good for home level TLC, almost all of the patients with mild work of breathing, the days of everybody under a month with RSV should be observed in case of apnea are really felt to be just about over. That I think had been a strong practice up until recently, but is not really felt to be indicated anymore unless you're truly seeing apnea. The moderate work of breathers also can typically be managed at home. And this is where it's really important to make sure the parents know that they weren't imagining it. They are looking for the right things. They are seeing retractions. They are seeing a change to their breathing. It's just a change that we're comfortable won't put them in danger in the next 12 to 18 hours. Not never, not 48 hours even, but that we feel comfortable that they are going to be safe to put them to bed that night, to see how they're doing in the morning, and ideally to follow with their pediatrician the next day to continue to monitor. And really not much role for sort of preemptively staying in the hospital based on, oh, but it's only day 3. But as long as the key is ensuring good follow-up and really excellent industry guidance. I did see a sad case recently where a very loving family truly thought they were following guidance, and they were told it's RSV, there's going to be work of breathing. And so they waited 5 more days to come back, and that child was in extremis and nearly had to be intubated. And so just making sure that we're reassuring, but also arming the parents appropriately with what they need to watch for and what sort of time frame they need to be seen again. Thus the pediatrician level TLC there as well. They need to be our partners in this. Finally, some of the patients with moderate work of breathing, despite it seeming moderate, might just not be able to feed, in which case IV or NG, either is valid. I think we underuse NG tubes. So in your hospital, if you're having trouble placing an IV, feel free to make that a backup option. super reasonable. Otherwise, if you can't oxygenate in this sort of moderate work of breathing group, then you may need low flow nasal cannula. And if the concern is really that they might not be able to keep this up, they're working so hard and so fast that you're concerned that they will tire in the near future, that's when we might need some of our more advanced support, which Dan is going to speak to in just a moment. Right before he does, I really want to hear from our nursing expert again, Hannah, with really her tips and tricks about how she helps these infants, and more so toddlers, they can fight us more strongly, to tolerate these interventions that can be agitating them, can be noxious to them.
Okay, so first we have child life specialists in the MGH PD emergency department, which are lovely. They're very helpful. They have a number of toys, light distractions, iPads, things like that are helpful. Also, I like to involve the parents just because obviously a parent knows their child best. So if a parent has a certain movie or music they like to put on to make the child more comfortable, I usually suggest that. The child already has a work of breathing, right? So you don't want to make them more distressed by upsetting them with strangers and making them cry, etc. Definitely involving the parents in child life. And then once you get the nasal cannula on, whether it's high flow, low flow, we have tegaderms that we like to secure to the face just to keep the cannula on. They're the clear, gentle films that we put over IVs. And then usually instruct the parents, if you see this coming off, just let us know. We're welcome to come into the room and re-secure that. We really just don't want the cannula to come out because once it's out, it's a battle to put it back in. And then warm blankets, wrapping the child in a warm blanket is helpful to try and really get the device secured. And yeah, it's usually a team effort, but by utilizing our child life, I think it's makes it a lot easier on both the parents and the child.
Yeah, I think those are really great points, Hannah. I will say that even we do not have child life many hours of the day. So we know that that's a luxurious resource that all places may not have. And while I don't want to in any way undermine their importance, I think we can extrapolate the sort of skills and tricks that they use that could be brought anywhere with any team. And so like Hannah said, pulling up a favorite video or song, it sounds silly, but the combination of that and papoosing, etc., at times can be magical. So really sort of hiding those arms, parent behind the child in the stretcher, cuddling them, aka holding their arms down, but cuddling, etc. And all of Hannah's great tips and tricks are just invaluable. Some nurses will come out and be like, they'll never tolerate it. And when Hannah comes out, they are always on the cannula. So it's deeply appreciated, the skills that are brought. I'm going to hand it over now to Dan, who's really going to walk us through what I know we all want to strengthen ourselves on and brings all of us anxiety, which is what are our advanced support? Once the suctioning is not enough, the low flow is not enough, they're still distressed, etc. What levels of advanced support can we use to support our patients with bronchiolitis? Dan, please take it away.
Sure. So we know that these patients often have an O2 requirement. But what do you think the mechanism is for that increased O2 requirement? It could certainly be V2 mismatch from atelectasis that occurs with mucus plugging, but often it's associated with the patient's increased work of breathing. And these other modalities are designed specifically to decrease that work of breathing. So we'll look at high flow nasal cannula, CPAP, non-invasive ventilation, which is sort of the next extension of CPAP. And we hope to God not invasive ventilation because these patients are very difficult to manage if they're intubated and ventilated. Next slide. So Nicole, I think, yeah, you're advancing slides. So this is our high flow nasal cannula setup. And it looks like a bit of a mess. You've got wires and cords and things in there. But this one is actually set up to deliver high flow oxygen, heated humidified high flow oxygen, and it's also capable of delivering continuous aerosolized bronchodilator. Now, even though we use the same device, we often consider the two modalities, high flow nasal cannula and continuous aerosolized bronchodilator, to be somewhat incompatible because of the flow rates required for each. Most of the time, as Nicole mentioned, patients with bronchiolitis don't require bronchodilators, but sometimes they do, and it gets to be a bit of a struggle. The high flow nasal cannula is defined as a high flow oxygen delivery device, which means that it meets or exceeds the patient's inspiratory flow demand. So once we determine what that flow is, we set the flow to achieve what we call the high flow effect, and then adjust the FiO2 as the work of breathing is relieved. Next, please. So the advantages of this are patient comfort and tolerance. And that's in comparison to CPAP, where for years we didn't have a good patient interface and were unable to provide consistent CPAP, and some of those patients got intubated. With the advent of the high flow nasal cannula, the patients tolerated it, kept it on, and many of them avoided intubation. So it is a high flow system, which means we can set the FiO2 and be confident that that setting is where the patient's FiO2 really is. Unlike some of the low flow systems where patients take a breath in and it mixes with the supplemental O2, and you really have no idea what their O2 requirement, which can be a strong indicator of their disease severity. They have to be heated and they have to be humidified. The device we use is the same humidifier we use on our ventilators, and it provides relative humidity of 90 to 100% at these high flow rates. The high flow effect that I mentioned is really twofold. We believe that there's a washout of a portion of the anatomic dead space which contains exhaled CO2. And on the next breath, that CO2 would normally be inhaled, which means it has to be eliminated through minute ventilation. So washing out a portion of that anatomic dead space can reduce the patient's work of breathing. It's also clear that they provide some level of CPAP, although we can't measure it. Studies have been done putting transducers in the larynx and looking at what the pressure changes are at different flow rates, and CPAP is definitely there, but it's not as much as one would think and is highly variable. The CPAP that these generate is related to the flow rate that we use, the cannula size versus the nares, and whether the patient's mouth is open or closed. Now, the cannula size should be about 50% of the size of the nares, but we have 2 cannulas and we have an infinite number of patient sizes. So it's hard to make that exactly 50%, but we want it to be open. We don't want it to be fully closed like a CPAP system because we don't want inadvertently high pressures to develop. And then once again, once the flow rate is determined, you should wean the FiO2 as the patient gets better, not the flow rate. So disadvantages, it's still a cannula. And as Hannah said, there are different ways to secure them, but patients don't like them. You can put a cannula on a mannequin as you're doing in-service education, but just try to put that on a 2-year-old who's squirming and turning his head left to right and just hating every bit of it. So it's still there. It's a little more difficult to set up than a standard nasal cannula, but that doesn't really stop us. It's not too difficult. There does remain some confusion and inconsistency about weaning the FiO2 and the flow and the variable CPAP that people think it's generating. We like to set the flow. That determines the high flow effect once again, and then wean the FiO2. And you can often wean the FiO2 very quickly down to like 30% in these patients. We have had some water in the patient circuits because of the high humidity, and that's it's always uncomfortable for the patient if it gets in their nose, but we have heated wires that prevent that pretty much. And the cost is really not an issue. Of course, it costs more than a standard cannula, but it's a whole lot cheaper than using CPAP or mechanical ventilation for these types of patients. So the disadvantages that we see, they're not insurmountable. Different people use different systems. They pretty much all work the same. Each manufacturer will tell you that theirs does something other than the others, but the way we use them as a high flow system, they really all work the same. The one we use here at Mass General is the Hudson RCI Comfort Flow System, but once again, they're all good humidifiers. They provide up to a 90 to 100% relative humidity at whatever temperature we set. And we don't set them at body temp. We don't set them at 37 like we do our ventilators. We set them a little bit lower than that because the upper airway is still intact. So there can be some heat and humidity added there. So we don't want to overheat them. But they all work pretty well, the same, and they all work pretty well. So these are the size cannulas we use. We use a pediatric and an infant size cannula. And people are asking, what's the ideal flow rate? And for a while, we didn't really know. We used to use estimates like It should be 3 times the patient's minute ventilation. I don't know what the patient's minute ventilation is. It should meet or exceed their inspiratory demand. I don't really know what their inspiratory demand is either. So we needed a place to set the flow and still ensure that it was a high flow system given these uncertainties. So initially we set them at the maximum flow rate per cannula size. And for the infant and pediatric cannulas, that was 8 and 20 liters per minute. But that's a big jump for a patient who just transitions up to the next cannula size. They went from 8 to 20. And some of our therapists who had a lot of skill would say, well, you know, I'll set it at 16 or 18 or 14 based on their experiences, but it wasn't exact. We went back and looked at the papers that showed success with high flow nasal cannula, looked at the patient sizes and the flow rates that they used, and it came out to be 1.5 to 2 liters per minute per kilogram. And since then, I think that's a pretty common way of setting the flow across the region. Some people may start a little bit lower and then turn it up if they don't get the response they need. We like to set it at 2 liters per minute per kid, and that's what's in our protocols. We're still subject to the maximum flow rates per cannula size, so we can't exceed 8 or 20 for those 2 cannulas. But within those ranges, we use 2 liters per minute. And more for adults than kids, we may adjust it a little bit for patient comfort, but we've been pretty consistent with setting them at 2 liters per minute per kilogram for our pediatric patients, and it seems to be well tolerated. So the benefits are the respiratory rate comes down. We use the RAS score, as Nicole indicated, and that's a numeric score, but there are some subjective components to that. So it can vary a little bit. In the emergency department, the docs are responsible for that. On the floors in the ICU, the nurses are responsible for it. I always ask the therapist to do it as well and compare their findings to be sure that we're getting consistent results. But the things that you can look at clearly are decreased respiratory rate, increased SpO2 or decreased O2 requirement, and decreased heart rate. Those things come down or go up immediately if the patient's tolerating it and having a good response. We see reduced work of breathing. That's not as objective as some of these other measures, but that's how we measure the success of CPAP. We turn it up until they stop retracting and their rates come down. As far as improved blood gases, we typically don't get blood gases. You know, we like to see numbers and we like to see that the CO2 and the pH have changed. But in reality, we're not getting blood gases on these patients. We might get a VBG or a CAP gas, but you know, they have minimal utility for looking at changes in patients' response to these devices. So typically, as Nicole said, you learn by looking at the patient, and that's what we encourage. But these objective measures of respiratory rate, SpO2, and heart rate, you know, they're solid numbers. So CPAP remains the gold standard. And as I said before, we didn't have good interfaces to provide CPAP, and a lot of patients got intubated some years ago simply because they wouldn't tolerate the CPAP. And the high flow cannulas prevented a lot of that. We have good devices now for patient interface. The choice of devices to provide the CPAP actually are CPAP drivers, ventilators, and you can use whichever ventilator that you're using now as long as it has a pediatric or neonatal patient size. We use bubble CPAP in our NICU. We've not used it for these patients, but there's no data that shows that either one of these is better or more effective than the other. So whatever you're using for CPAP, if you've got a good interface and you're generating CPAP, I think it's going to be sufficient. So there are a couple of lines left back there, Nicole. So what's the optimal level of CPAP? We'll get to that. And the patient device or interface, this is what's made the difference. So this RAM cannula is a device that came around 5 years ago or so. It's hard to know. And they're much better tolerated than any of the masks we ever used before. And they generate a good seal. So we can actually provide good CPAP with a good interface that the patients will keep on and achieve the CPAP levels that we want. So that's really made the difference. It's the interface. So we're tending to use a little more CPAP now than we did probably even last year. Next, please. So different devices, right? These are NICU prongs. that you've all seen and used. And, you know, they're all kind of cute. They all fit and they work a little bit differently. And these have served us well, you know, in the NICU, but they really didn't provide a good seal for these bronchiolitis patients who are a little bit larger than those patients in the NICU. So the ram cannula, I'm going to show you a picture of that. You probably are using it. Is the patient comfort I described. It's easier to put on, but as Hannah will tell you, nothing's easy to put on these patients, but certainly easier to put on than a mask. It improves the patient's access to CPAP, really. It has made the difference. Fewer disruptions, the patients aren't tearing them off and then, you know, coming off, and they don't have to like tighten down really hard. So it may decrease the incidence of pressure ulcers as well. You know, CPAP masks should be snug but not tight, but when they're leaking, people have a tendency to tighten them up a little bit. But they really shouldn't be super tight, and the devices are all very good at dealing with leaks. Next. So here's the ram cannula. It is designed as an occlusive interface. So it's designed to be used with positive pressure ventilation and CPAP devices. It has a tighter fit in the nose itself and allows more transmission of the pressure to the patient. Device triggering and patient synchrony can still be an issue. The better the fit, the better that works. But we still have patients who are out of sync with the ventilator. On CPAP, that's not really a big problem. With non-invasive ventilation, it can be a little bit problematic if they're not treating the device properly. But this should not be used for a high flow nasal cannula. They're different. Okay? So let's go and see what we do for these patients who we start on high flow nasal cannula in the emergency department, and then we want to send them up to the floors. Well, you can't really transport them on a high flow nasal cannula. It's really difficult to provide heat and humidity for these patients because the heated humidifiers draw a lot of electricity. We've got one battery that lasts like 20 minutes, and you really can't transport them dry without heated humidity with a high flow nasal cannula. The way it works, it will dry the secretions. It's actually quite painful. I thought, you know, maybe we'll just, like, when we're ready to go, we'll unplug it, we'll go quickly up to the floor and plug it back in. How bad can that be? Well, I put one on myself at adult flow rates in my office, and I thought I would do a little bit of work while it was on, and without heat and humidity. After 2 minutes, it was painful, and I had to remove it, and it was still painful for some time after that. So transporting them on high flow nasal cannula without the heat and humidity is not an option. So one of our pediatricians, Ari Cohen in the emergency department, asked me, do we have a portable CPAP device that we can move them on? And I thought about it, and I said, yeah, we can use a Mapleson bag with a ram cannula. Why not, right? And even though it's dry, the flow is not the same as the high flow nasal cannula. The high flow, that flow is directed through the nose directly into the respiratory tract, and the patient generates some CPAP by exhaling against it. With CPAP, the pressure is really in the system and it's regulated, and the patient only draws the flow that they need. And again, it's only for a short period of time. So this is how we move the patients from the emergency department to the floors. This is a comparison of the high flow nasal cannula on the right, the ram cannula on the left, and these are both pediatric size. So these should be the same, but of course they're for different applications, and you can see the difference. The one on the right, the high flow nasal cannula, is designed to fit with a leak, and the one on the left is designed to be more occlusive, where the device itself, whether it be the Mapleson bag or the CPAP system, regulates the pressure. There is no such pressure regulation in a high flow nasal cannula. So here's the setup. You set the flow with it occluded. You use that blue valve to adjust the pressure. Remove the cap, put the cannula on, and once you place it in the patient's nose, the CPAP will be generated, and then you can fine-tune that adjustment. And we aim, next slide, to 5 to 7 centimeters of water to start with the nasal CPAP, and that seems to be sufficient. Prior to this, we were taking them off the high flow in the emergency department, sending them up to the floor, telling everyone they were stable, yet when they got there, having lost the high flow effect, they were tachypnic and tachycardic and desatting, and so they went to the PICU. So this has made a big difference for us. Someone asked earlier, where do you set the CPAP on patients who require CPAP? And we used to set it at 5 for everyone. I think a lot of people set it at 6, and then you titrate it up from there based on the response. Well, this paper shows different levels of CPAP and how it relieved worker breathing. This was a case series of 10 patients, and the worker breathing is shown on the left, and as indicated by pressure time product of the esophagus and the pressure time product of the diaphragm on the right. And these are generated with esophageal balloons. So you can put the balloons in, measure the changes in pressure, the negative deflection, how long it's there, calculate that area, and come up with a number that we call pressure time product. And according to this data, it looks like 7 was the best place to start, at least in these patients. So we've instructed our staff to start CPAP at 7 rather than 5 or 6. And again, once you started, we titrated up from there.
Perfect. Thank you so much, Dan, for that. I know, how the sort of ins and outs of some of that support is what causes some of us the most angst. Really appreciate that. We did want to intentionally spend the majority of our time on bronchiolitis. That is what is so very pediatric specific, and certainly our colleagues in all community settings do take care of asthma in all ages, and so much less of a foreign topic. So I think we do want to make sure we leave time for questions. We could perhaps just run. We can either pause here, again, knowing the bronchiolitis is the most PD specific, or we could run through this just in the next 2 minutes and make sure we leave time for questions. What do you recommend, Dr. Bittender?
I'd say let's do a quick run through the asthma just for now. And then just so folks know, we are capturing all of your questions. I unfortunately don't think we're going to be able to get to all of the questions, but we will make sure that we note them, and either if we can put up a Q&A along with the slides and the taped recording on our website, rdhrs.org, and or fold some of this content into our next session. We'll make sure that we get these answers to you. The questions have been phenomenal, and we really appreciate them. So let's do a little bit of asthma, and then Nicole, I'll try and get the questions to you as quickly as I can.
All right. So again, you all know asthma, small airway disease, inflammation, and spasm. It is the most common chronic disease of childhood. Unfortunately, deaths are actually rising in pediatric patients, predominantly in the pre-hospital setting. And of course, we all know the typical exposures and triggers. Our mainstays of therapy, you all know this: inhaled bronchodilators, PO or IV steroids, IV magnesium being a common adjunct. Just a few things there that I think we sometimes maybe don't capitalize on as much as we could in our quest currently to really safely discharge whoever we can in the current crisis. Just might be helpful to remember that there is good data that if we add ipratropium to our bronchodilator regimen, so the use of DuoNebs as opposed to straight albuterol nebs in any patients with severe asthma, for every 7 patients we do that for, we'll prevent 1 admission. And so that can be really powerful as we're all struggling and tight and trying to get kids home safely when there are no beds. Similarly, if we administer steroids within 1 hour of arrival, for every 8 patients that we do that, we will prevent 1 admission. And that is actually Cochrane review level of data, which you never get in pediatrics. So might be worth trying as you sort of figure out where to focus your energy, considering both of those points. Otherwise, certainly for the very ill patient, incredibly uncommon. Other adjuncts that could be considered before the sort of respiratory support beyond this is IM epinephrine or sub-Q or drip version of terbutaline. Again, really uncommon, but those patients that you're concerned may be truly approaching positive pressure ventilation or even intubation, which of course, with it being a disease that you cannot get air out, you want to do everything you can to prevent having to turn it into a process where you're pushing air in. I'm going to just run through this incredibly quickly. Again, a plug for, look, there are pathways available, and there is great data that use of standardized pathways, particularly specifically in asthma, improves outcomes, decreases admissions. In terms of assessing your interventions, I think we really went over that before. All the sort of same, how's their mental status, their work of breathing, the respiratory rate, how's it compared before and after, and I think we'll sort of keep moving there. In terms of advanced support, of course, the typical mainstay for those that are not sort of doing well enough on intermittent nebs despite steroids and appropriately dosed mag, continuous bronchodilators are really the mainstay of therapy and will do well by the vast majority of children. It is incredibly uncommon to need to progress to non-invasive ventilation, or certainly, again, invasive ventilation. Dan, you have time to answer the questions about your therapy, so I'm just going to run here, which is just to say, really, when they fail their DuoNebs is when CAB is indicated. Here is some dosing. Again, it's just a plug for using any standardized reference. You don't have to think about all this yourself. Here is sort of what the high flow setup tends to look like. You can certainly, so the continuous setup rather, you can certainly mimic it with sort of frequent nebs as needed until an RT is available to help you to keep your patient safe. But ultimately, this is a bit more resource friendly. If you do have to move to non-invasive ventilation, again, it's really rare, but if they're truly looking, they're going to fatigue, then you may need to. Synchrony, as Dan helpfully wrote in this slide, is really essential. But know that it is deeply imperfect. Aerosol delivery might be compromised. We really want to do everything we can with those other adjuncts before getting to this point. And certainly same for intubation. It is deeply imperfect to intubate somebody with asthma, as you all know. Here are some really helpful sort of tips if we arose to that point that Dan was able to include here on the slides, but doing absolutely everything we can with all the rest of the adjuncts and data-driven therapy to avoid this point is really critical. I'm going to close here, which is just saying that kids are having a tough season, but they are also really resilient. You guys know sick and not sick is actually so much simpler than so much of what you do. Hopefully any of just the sort of PD tips and tricks that we, and especially Hannah and Dan, were able to provide are all helpful. And we just really appreciate the work everybody's doing to take excellent care of children. I'm sorry that you ran tight on questions. Please, Dr. Bittender, take it away.
No, thank you so much to Dr. Nadeau, to Hannah, to Dan. It was a fantastic talk, and we really appreciate it. Again, I apologize that we are running short on time. I would remind you that we have 5 more sessions beyond this, including some focus sessions on high flow nasal cannula and CPAP specifically. So I'm just going to ask a couple of the targeted questions. Then again, we'll cull through the ones that are submitted and try and see if we can't put up some FAQs even before next week. There are a lot of questions about suctioning and Hannah and Dan in particular. Can you just talk about your approach to suctioning, deep suctioning? For folks who don't care for really small children regularly, it can be a bit intimidating. Tips and tricks as well as indications.
Yeah, so as you know, suctioning is typically not recommended by the American Academy of Pediatrics for these patients. Patients who are more severely ill and have a lot of secretions do in fact need suctioning, and we try to do some tracheal suctioning when indicated. We do a lot of the, I think they call it the bebop device. It's a kind of a mushroom device that will fit into the nares, and you can clean out the nose, which is huge. There's a lot of resistance there from those secretions, particularly when they come impacted. And the work of breathing can be reduced tremendously by cleaning out the nose. But occasionally we do deep endotracheal suctioning. I think we tend to overdo it a little bit, but sometimes you just really have to do it. And it clears out their, really it's just their trachea. Think about it. If the patients are coughing, that's better than suction because they're mobilizing secretions deeper in the respiratory tract. We can't get much more than into the trachea with a suction catheter. Perfect.
Hannah, anything you wanted to add to that?
Just kind of reiterating what Dan said, the nose, especially with babies, when they're feeding. If you think about it, the bottle's in the mouth, they can't breathe through their nose because secretions, oftentimes just a bulb suction, sometimes a little saline to kind of like loosen everything up, and just a bulb is helpful. And of course, just return demonstration by the parents just to make sure they're doing it correctly at home is helpful too. But just something as simple as clearing out the nose can even make feeding a lot better for the little ones.
Perfect. 2 last questions, and Dr. Nadeau, I'll try and throw them both your way at the same time. One is just the value of testing in general. When is testing for RSV helpful? When is it not? And though we will absolutely address this in some future webinars shortly, just that admission decision. Do you have any parting words on that admit, go home decision that can be so hard for everybody?
Yeah, absolutely. The truth is I don't think testing is terribly valuable. So if that in any way becomes a limited resource, I would not fret. I think, we test everyone only because of COVID still. And so that still has some public health implications for isolation. And that test happens to come with flu and RSV. Flu we sometimes treat, but RSV really doesn't change our management. So we only know these numbers because we are getting them with our COVID swab, and now maybe we're trending them epidemiologically. Otherwise, really sort of broad viral testing only helps for cohorting upstairs and patients that you're admitting. It doesn't in any way change your management. Again, the management is really all supportive, and that's not going to change whether it's from rhino, from RSV, et cetera. And the bigger question of the sort of to admit or not, I will say my threshold has increased this season. There is not, every individual patient needs to get whatever they need, regardless of the system. And so if they need to be in the hallway of the ER to stay safe, then they will all pile there. But I think I used to think if I was worried they were going to worsen in the next 24 hours, right? If they had moderate breathing, not just mild to moderate. If they were feeding less, I would worry about them a bit, but really those kids are okay. We do need to sort of count on our parents with really good, clear guidance. If we think they're safe in the next 12 to 18 hours, if they're drinking not as much as usual, but enough to hydrate, a little pee every 6 to 8 hours, a little avoid every 6 to 8 hours. If they have, reasonable, if they have work of breathing that's almost impressing you, but they're still feeding like a champ, then they probably still have great respiratory reserve. And so it's that sort of constellation together, how they're telling you what the reserve is like right now, that I really try to make my decision.
That's great. Well, again, one more enormous statement of thanks to all three of our incredible panelists. We hope this has been helpful. Again, this webinar will be archived. It'll be posted on our website, rdhrs.org, relatively shortly. Please, if you think there are others that might want to watch this, feel free to forward the link. We will post the slides on the same website, and as well as links to the CHOP and the Seattle and the MGH tools. Thanks to everyone who helped put this together. We will see you next week. Thank you all.
Thank you so much, all.